Hi everyone. Thank you for joining us for our recovery-oriented practice from the Housing First principles. I would like to acknowledge the traditional owners of the lands on which we meet today. We acknowledge that we meet on many lands of Aboriginal people, and we pay our respects to their elders, past, present, and emerging. We extend that acknowledgement and respect to any Aboriginal and Torres Strait Islander people who are here today. I acknowledge that sovereignty was never ceded. This was and always will be Aboriginal land. So on this webinar today, we have Alice from Newtown Neighbourhood Centre in New South Wales, and myself, Linda Townsend, from Tamworth Family Support Services in New South Wales. So I am the service manager for the Special Homelessness Service, Women's and Children's Refuge and Staying Home Leaving Violence programs in regional New South Wales.
And I'm the team leader for the Together Home program at Newtown Neighbourhood Centre, which is a Housing First program that assists people moving from rough sleeping into permanent accommodation.
Thanks, Alice.
So over the last few weeks, you've heard from a lot of different speakers who've discussed the Housing First principles, including that people have a right to a home, that housing and support should be separate, choice and self-determination, flexible support for as long as needed, active engagement without coercion, and social and community inclusion. Today, we're going to discuss recovery-oriented practice, and in our next webinar, our final webinar in this series, we're going to talk about harm reduction. Recovery-oriented practice is a potential-based practice that recognises people's capabilities rather than their deficits. It exists somewhat in opposition to the biomedical diagnosis-based model, where mental ill health is viewed separately to life circumstances and is treated medically. Recovery-oriented practice is all about the understanding that everyone is entitled to and should expect a meaningful and satisfying life. It's an approach that promotes well-being, that builds upon strengths, that embraces a variety of perspectives, and perhaps most importantly, recovery-oriented practice allows for people to develop their own interpretation of recovery and how it fits into everyday life. Recovery-oriented practice acknowledges that each person is the expert within their own life and that the only person who can decide what's right for them is that person. Recovery-oriented practice was initially designed to assist people experiencing mental ill health or issues with substance use and wasn't explicitly designed for application in the homelessness space. With that said, a founding tenet of Housing First is that people don't need to earn their housing or access to support that helps them live a meaningful life. And like I just said, that's a vital component of recovery-oriented practice too. Similarly, we know that people experiencing homelessness have an extremely high instance of mental ill health, experiences of trauma or drug and alcohol issues. So it's kind of a no-brainer to apply it in this space too. In the same vein, it's impossible to understate the importance of secure, quality and appropriately located housing in the management and recovery from factors that contributed to the initial experience of homelessness. In Australia, recovery-oriented practice is a core component of ongoing policy reforms in homelessness and mental health at a national level. In Housing First programs, we see recovery-oriented practice as a defining part of service delivery. As is the case with all the principles we've seen in this series so far, without recovery-oriented practice, you can't have Housing First. Now I'm going to talk a little bit about the individual components of recovery-oriented practice according to Australia's Housing First model. So the first principle is, unsurprisingly, recovery. The principle of recovery recognises that the symptoms people experience are not necessarily an illness and they don't necessarily necessitate a cure. Rather, we should be working to assist people to live a meaningful, satisfying and purposeful life where they feel they're a valued member of their community. Recovery is holistic and goes beyond a mental or physical health focus to find individualised recovery outcomes. Importantly, recovery empowers individuals to recognise that they're at the centre of the care and the support that they receive. Housing First programs are designed to work with people who you could call entrenched in homelessness, people who have spent years of their lives, often 10 or 20 or 30 years, without stable accommodation. A common factor in the conversations that I've had with these people is the identification that without housing, it's impossible to work towards long-term goals. You're too focused on staying safe, or where your next shower is coming from, or where your next meal is coming from. When you're housed, you can work to let go of this survival mindset and start thinking into the future, into what's important for you, and into actually setting goals that you want to work towards. And that's what housing first and recovery oriented practice is all about, assisting someone to find the stability to look into what they want to achieve and then helping them achieve it. When we're talking about recovery, we have to talk about the importance of hope. Without hope, what's the point really? We live and we work in a system that's historically associated shorter life expectancies and worse quality of life with certain mental health diagnoses or life experiences, and that includes experiences of homelessness. It's our job as workers in this space to question these assumptions and hold the belief that the people we work with are entitled to a full and meaningful life, that phrase again, and that they can achieve this, whatever it looks like for them. Evidence actually shows that belief in recovery is half the battle. To do this, we have to ensure we're acting based on what's important to the person we're working with and what their goals are. We should work to promote and protect human, legal, and citizenship rights. We should also remember the importance of meaningful social, recreational, occupational, and vocational activities when we're working holistically with people. In a study conducted in Canada in 2014 by Hurst et al. On the narratives of hope in recovery in a Housing First program, it was found that overall participants were more able to clearly visualise their goals for recovery and recognise the significant role that stable housing and support played in that. It was also found that those who had difficulty adjusting to housing, and in particular socially isolated people, they didn't experience this hope for recovery in the same way, and this could impede their long-term outcomes. This really highlights the importance of support, but also highlights that support needs to hold that belief for people that they're working with, even when they can't hold it for themselves. I've put the reference for this study on this slide if you're interested in reading it. So dignity of risk is a principle closely linked to choice and control in Housing First. Dignity of risk refers to the right to be able to live a life that you choose, even if those choices involve risk. Another term for dignity of risk that I quite like is risk enablement, or the concept that taking considered risks actually enables or empowers individuals and positively affects their overall well-being. When you think about it, everything we do involves risk. We drive a car knowing that there's a chance that we might crash or be crashed into. We exercise or we don't, and there's different risks associated with both of those options. When we're supporting someone, it can feel really tricky when they make choices that you may consider harmful, like smoking cigarettes or something like that. But the important thing to remember with that is that if you as an adult are entitled to make that choice, then the person you're working with is too. Dignity of risk is often impeded by a misplaced understanding of duty of care. In Australia, duty of care refers to the legal obligation to not cause foreseeable harm to another person or their property. We do have a duty to step in if there's an immediate risk of death, permanent disability, a legally determined lack of capacity, or if someone is subject to an intervention or court-directed treatment order. But the important word there is if there's an immediate risk. Beyond this, our obligation is to prioritising the dignity, the autonomy, and the choice of the people that we work with. Strengths-based. This is another term we see bandied around a lot, and with good reason. A vital part of recovery is adopting a strengths-based framework when we're working with people. It's important to note that this doesn't mean ignoring or minimising the very real impact of systemic issues, of trauma, and other issues that lead to their experiences of homelessness. Rather, it means looking at an individual based on their protective factors and their natural aptitudes. Hoovast, which is a word I've definitely mispronounced, is the Dutch word for grip. And it's a strengths-based approach designed for assisting young people experiencing homelessness, but it can be broadly applied. Hoovast approaches emphasise the strengths of the individual and aims to build their confidence, their autonomy, and their self-reliance as they approach their recovery. A randomised study found that participants experienced improvement in their quality of life, in their satisfaction with family relationships, in their finances, in their health. They were in employment or education. There were lower instances of depression, lower care needs, and probably most importantly, the participants had an increased experience of autonomy, competence, and resilience. Finally, a really important part of recovery-oriented practice is that support provided should be appropriate to someone's cultural identity, to their gender identity, to their developmental stage, and to their preferences. This helps in building rapport and trust with supports, and it helps in identifying goals to work towards. People's experience of recovery will be influenced by, like I said, their cultural identity or the way they see themselves, their kinships, and their relationship with the broader community, their experiences with torture, trauma, displacement, or loss, their experiences of racism or discrimination, the way they communicate distress, wellness, illness, anything really, their spirituality, and many, many other factors. Research shows that there is an overrepresentation of Aboriginal people in the LGBTQIA+ community and the culturally and linguistically diverse or COLD community within homelessness, as well as, like I said earlier, people with experiences of mental ill health, with drug or alcohol issues and experiences with trauma. We also see women over 55 as the biggest increasing population of homeless people in Australia. So I think we can agree that regardless of the other intersections, homelessness in itself leads to experiences of discrimination, displacement, and profound loss. This is why it's so important to provide supports that are appropriate to a person, that have a good understanding of both their situation and what's important to them, and that are created in consultation with that person. Now I'm going to hand back over to Linda, who's going to talk about the practice implications of recovery-oriented practice.
So thank you, Alice. So I guess from what we've listened to from Alice, recovery-oriented practice seems pretty straightforward. But as we will see, there are some practice implications to consider. While what we've provided today is not exhaustive, but we have provided some for you to think about. We are sure that you could identify more that may be evident within your own workplaces. These are not reasons to discard a recovery-oriented approach, but more a guide to start the thinking process on overcoming these and implementing recovery-oriented practices into the work that you do. Many organisational policies allude to a person needing to be abstinent to receive a service, or their mental health should be stable and they should be ready. But what is ready? Ready is different to many people, and trying to fit this word to mean the same for everyone is nearly impossible. Recovery-oriented practice moves beyond the mental health, the drug and alcohol diagnosis, and assists in the non-medical aspects of a person's life. I would like you to consider creating a culture and a language that promotes hope. Remembering recovery is personal. It occurs in the context of one's life, and most of all, recovery is about transforming services and the systems. Consider reframing the language and promote the rights to have a fulfilling life. For the managers out there, let's consider these people as they go on their journey, and let's hire potential. So the biomedical model. So most of our healthcare philosophies come from the embedded biomedical model. Without this model, we wouldn't be where we are in terms of understanding the human body and how, for most part, it works. We wouldn't understand the disease processes and how they interact within an individual's body. Basically, there is a belief that all diseases have a physical cause and they can be treated. The interaction between doctor and person is often a power imbalance, where the person adopts a submissive role and they believe the doctor can fix their ailment. The person will often have little involvement in their care. The model does little to address any of the root causes or the underlying factors that contribute to illness. You're either healthy or you're unhealthy. The biomedical model tends to favour pharmaceuticals over other types of treatment, such as diets or exercise. In some cases, it even fails to view the person in a holistic sense. Some other practice implications that we may often see in the recovery-oriented practice are our organisational policies and procedures. So many organisations have a robust set of policies and procedures that govern the way we work. They are often based on workplace health and safety, and rightly so. However, they often contain risk assessments that prohibit us from working with people who are under the influence or who maybe experience a period of unstable mental health. Then we have system structures. So the structures and systems around us consider eligibility requirements. What about rehabs? Some actually require the person to be detoxed before they can enter. Housing, the person needs to demonstrate that they are housing ready. And if they have an inspection and there is evidence of drug or alcohol use, it raises concerns. they may not be able to sustain the tenancy. I personally recall an incident of this very nature. A person that we'd worked with had a significant drug addiction. They had worked so hard on their recovery where they were no longer using injectable drugs, but they, were still using marijuana. And when that property agent was there, they spied the implement that was used to smoke it. All of a sudden, this particular person's tenancy was at risk. There was no consideration to their recovery so far. So this person had worked so hard and their recovery was in a really great place, but because society's attitudes and the structures and things around us said that, obviously their tenancy was at risk because this person was using the lesser of the drugs. We have a resistance to change. So often we look at the staff and community attitudes towards recovery. Consider a person attending accident and emergency. They're quite unwell and they may have a past drug history. It's evident, and perhaps they're coming from a trauma base. They're scared. They may have diminished capacity to understand and be rational in that moment, and they become verbally hostile. Immediately, we know security and all the police are called. Now, I'm not suggesting for a moment that we forget about our safety protocols or our procedures and all the things that govern the way we work. But just consider for a moment, how do these contribute to a recovery-oriented practice? Are we looking for strengths within the person and building from there? Unfortunately, although there is a shift, we still focus on what is wrong with the people. We list their issues and one by one develop a plan that's going to fix them. Why? Perhaps it's because we also work subconsciously through the lens of the biomedical model and unwittingly buy into the stigmas. Stigmas still play a big role in recovery-oriented practice. Unfortunately, mental health and drug and alcohol issues are often viewed as a weakness. Maybe consider reframing language and promote the rights to have a fulfilling life. For any hiring manager, let's hire potential. We've said that before. Many people with mental health have a range of skills that the sector needs. Housing and employment is a step further to recovery. So I'm now going to talk to you about the integrated recovery approach model. So Housing First works with the person and builds upon hope. So that's the white section in the middle of this slide. To do this, we need an integrated approach. Housing First is only one component. A person's recovery will occur within a web of relationship, which includes the individual at the very centre, their families and their communities, which can often be contextualised by their culture. So as Alice said earlier, privilege, oppression, history, and social determinants of what health is. Recovery occurs for an individual within the context of their gender, age, and the developmental stages. For us to truly understand the people we work with, we need to listen to what recovery means for them. And most of a person's recovery is going to happen at home. So their family, friends, and communities, they're all going to have an important role to play. The significance of community connection and participation in a person's recovery highlights the importance for not only services but practitioners who may be involved in the person's support to address the social determinants of health and well-being. We need to understand that the effects of discrimination and other social consequences of having a mental illness or a drug and alcohol history may all impede recovery. So this particular slide, so in the remediation stage, this is where an individual recovers psychological and physical well-being. It begins the process of recovery by reinstating a sense of possibility. Our primary providers in this space are going to be our acute mental health services. Restoration, regaining competencies, focus on building hope through the collaborative restoration of function, self, agency and participation. In here, this is where we're going to be looking at mental health, clinical services, our rehab. The housing first, we work within the person recovery needs. So building hope, helping with wellness, challenging stigma, substance misuse and supporting people to, develop plans around what is recovery for them, their friends, accommodation, relationships, all of those things entwined together. And at the end of it, what we're going to end up with is reconnection. So reconnection with place and society by re-establishing a place in the community with a range of skills and supports that actually encourage community participation and the exploration of new opportunities is where most of the work that we do in the NGO sector. We also rely significantly on our GPs. But to get to recovery, we're building resilience, self-agency and social inclusion for the people that we support.
I was on mute. We just wanted to end with a quote from Samson Barrett, who's the founder of Housing First, who is a wonderful human being if you ever get the chance to look him up. He said, the first part of finding a solution is to include in the conversation the people we're actually working with, the people on the street. And we're going to leave it there, but we do have time for a couple of questions. And I see that some people have already made use of the Q&A box that we forgot to mention at the start of this webinar. So if anyone else wants to send one through, feel free to do that now.
Thanks so much, Linda and Alice. The first question that I'd like to, whoever would like to jump into this, someone's asked, how can I work better to instill hope in consumers when often even after they have housing, they're still in poverty, facing social exclusion, unable to get work and so on?
Yeah, I can take this one. I think that's a really normal way for people to feel as they enter housing. When I first started in this role, I kind of felt like people would move from rough sleeping into housing and kind of feel like their problems had been solved, which we know through Housing First, through research, through everything isn't the case. And it actually can be a big trigger for someone to start experiencing a crisis. And that's where having the right support around is really important. So having someone that actually understands that this is a really big moment of change for someone and that they're going to need extra support and they're going to need extra help to find connection in their community. That's a really protective factor in that. And then I've also found with some people that if they, for example, were rough sleeping in the middle of the city where they had a big community where everyone kind of looked out for each other, and then we moved into the suburbs into an apartment where, they can't even walk to the train station, that's a really big risk factor for them feeling really isolated. So my answer is kind of vague, but I think if we have the right supports and if people are housed appropriately and if we're all aware of the challenges of moving into housing when you've had a period of rough sleeping, that's a really good way to start.
Thanks so much for that, Alice. And the second question I have in the chat asks, how can we manage or deliver recovery-oriented practice when it's so hard to get people in to get mental health support? I'm not sure if, Linda, you'd like to take that one.
Yeah, sure. Look, we all know that, within New South Wales and for, much of Australia, our services are quite burdened. We have, a lot of waiting lists and things are, you often hear that things are in dire straits for some people. They're refusing service and whatever. I think one of the most important things in the Housing First model is that we are working with those clients or those people around areas that we can improve. So when we've seen this slide about the areas that we work, so about their social skills, about building, their social connections, keeping that hope alive for that individual. If we continue to work around those spaces and continue to advocate for access into the mental health system, it will eventually come. It's a very, very complicated path to navigate. But I think, you know, the more we can continue to build a person, their social connections, their, you know, reconnect them with families, friends, social activities, employment and things like that, the mental health services aren't going to necessarily be the first point of call for some of these people.
Sorry, my turn to be on mute. Thanks so much for that, Linda. That brings us to the end of the questions we've received. I'm just going to put a link in to register for our final webinars.
Yep. On that note, our final webinar will be on the 8th of November at 1:30 Eastern Standard Time. And that one will be on harm reduction. That'll be the last webinar for this series, so I recommend tuning in.
Yeah. And just lastly, before we go, so I'd like to thank you, the viewers that have joined us today. We'd also like to thank the Lord Mayor's Charitable Foundation in Melbourne, Homelessness Australia, the Council to Homelessness People, and the Housing First community of practice, who collate most of the materials in this presentation.
And I'd like to thank Alice and Linda for being here today and sharing your practice expertise, and thank everyone who's coming to join us today. Have a great rest of the day.
Thank you.
Thanks. Bye.
Bye, everybody.